Thank you, Xiangping. Truly is a pleasure to be back. It's been a trip down memory lane for me, and I've enjoyed every moment of it. So I'm happy to talk to you today about a couple of interesting things that we've been doing at the Cleveland Clinic. So I've sort of divided the talk into two halves. The first is talking about more of a therapeutic nuclear medicine use, and then I'll get into a little bit of more of a diagnostic, some novel diagnostics in the second half. So this first part is a determination of radiation-absorbed dose to primary liver tumors and normal liver tissue using post-radioembolization Y90 PET. So I realize that probably most of you in the audience are not in nuclear medicine. So I'll try to explain the setting here very quickly as to what the situation and why this is useful. Basically, there are patients who get cancers that metastasize to the liver. Or it can be a primary liver cancer. So we're basically talking about hepatocellular carcinoma or potentially something like colorectal cancer, which metastasizes to the liver. This particular study that we did was specifically in HCC, or in hepatocellular carcinoma. And often that tumor doesn't confine itself to just one region of the liver, but unfortunately disseminates through many aspects of the liver to many lobes. And so then they become non-surgical candidates. At that point, the life expectancy of the patient is very, very little, and you're looking for some sort of means to maybe either get that patient into the category of becoming a transplant candidate because they have criteria for fitting into that, and if you can sort of downstage the tumor, as they say, that's sort of the ideal scenario, that then they could go on to get a liver transplant. Even if that is not possible, still it's been shown that Y90, yttrium-90, which is a beta emitter, has increased survival for the patients of up to 10 months. So it's advantageous to the patients to get the treatment. So we'll talk a little bit more about it. And oh yeah, I always forget about this. So I'm on the National Speakers Bureau for Bayer Healthcare for radium-223, which is used for prostate cancer. I am a speaker for Certex, which is one of the manufacturers of Y90, and for biocompatibles. This is the resin Y90 product. This is the glass Y90 product. So as I just mentioned, the radioembolization has actually been FDA approved for treatment of HCC for more than 10 years now, but it's just in the recent time that it's become more widely used for unresectable HCC. So it's only been in just the last couple of years that it's been found that a yttrium-90 PET scan can be acquired to determine the distribution of microspheres after their administration. And this is because there's a very small branching ratio of the yttrium-90 decay that's positron. The rest of it, the 99% of it, is actually beta, which is the therapeutic effect that we're looking for. So while the obvious advantage of PET is better resolution than a Bremsstrahlung scan, before that people realized that you could do yttrium-90 PET, there was many people, our group included, that was doing what's known as Bremsstrahlung imaging. And so those of you who are more familiar with X-ray or CTs know that Bremsstrahlung is a process which actually generates the X-rays. The same thing actually happens in the tissue, that when beta particles are emitted from the yttrium-90, they actually give some of their energy to atoms that are nearby, and they lose their kinetic energy, and therefore you get Bremsstrahlung radiation out of the patient's liver. And you can actually widen your energy windows on a SPECT camera and obtain a Bremsstrahlung image. The downside is that the resolution is extremely poor, and it's non-quantitative. It's very, very fuzzy imaging. So it's a very, very gross estimation, whereas PET tends to be much higher in resolution and less quantitative. So at this time, dosimetry in radioembolization is very primitive and somewhat arbitrary. It's usually either based on the liver lobe volume or the body surface area of the patient. These are the manufacturer-recommended formulas and how they determine how much dose needs to be given. They don't actually they don't have any sort of target gray to either tumors or livers. So in this retrospective study, we had 56 patients, all of whom had HCC. They had 98 distinct tumors, and they were analyzed after the yttrium-90 glass microsphere treatment. And the purpose was to evaluate the dose of radiation either delivered to the liver tumor or to the normal liver tissue. We used yttrium-90 PET CTs and triphasic liver CT scans in conjunction with commercially available imaging software to contour out the tumor and normal liver regions treated by the Y90. And then we wanted to determine the specific activity in becquerel per ml for both treated tumor and normal liver. So it's a very simple concept. Oh, a little justification problem. Sorry there. So we have an absorbed dose factor. This would basically take into account the isotope branching ratio, the decay of the isotope. The half-life of yttrium is about 3 days, a little bit less than 3 days. We verified the accuracy through a phantom experiment to see that we were actually getting activities that were of a reasonable value from our PET scanner, and we had less than a 4% error. So we felt like it was accurate. And we converted this activity in becquerels per ml to gray using this formula here. So what you see basically are the two branching ratios. Why is there a germanium decay in here? Because the PET scanners are not, yttrium-90 is not a typically imaged isotope. So when you acquire a PET scan, you have to choose the isotope that you're imaging. And germanium is a commonly found one in PET scanners. So we sort of use that as our surrogate, and when we correct for it by having branching ratios to convert the germanium decays into yttrium decays. So we take the specific activity that comes from the scanner, and we have a factor here for MERD dosimetry as well as decay, and come out with the actual dose of yttrium-90. So the way that this was done was that basically the liver was separated into two compartments. We separated into a tumor compartment and a normal liver compartment. And right here you can see an example. This is an axial slice that has a region drawn around the right lobe of the liver. And this is what a yttrium-90 PET scan may actually look like. So then what we did was we sort of broke this down into the volume and the specific activity in each of those compartments. And the reason for doing that is to actually calculate the specific activity in the normal liver, because this number we converted into gray, and this number we converted into gray. Those were our two key pieces of information that we were looking for. So we basically just did some simple algebra to solve for the specific activity of the normal liver tissue. So to give you an example of how this looked in practice, here this is a arterial phase abdominal CT scan, so it means early contrast after the iodine is given. And typically HTC enhances early, and so arterial phase CT is the optimal way to image visualize this HTC tumors. But then you would see the yttrium-90 PET would never actually line up with the contrast-enhanced CT. It's because this is done in a breath hold fashion. This is very quick. This acquisition is done over half an hour, so you have free breathing, and of course, the misregistration is inevitable. And so what we did was we used a special software. It's called MIM Vista software. They have a deformable registration tool where you can actually deform one scan to the other. And so then you would see that where this originally came from that scan, that this CT scan was then deformed to match the Y90 PET, and then this region was in turn deformed with the scan. So on the next slide, you'll see what it looks like now after it's been deformed. So we can match up the activity that belongs in that tumor much more accurately. So then we have the counts, or the specific activity that are within that contour, and we can convert that to gray using the formula that I showed on a couple of slides before. So we did that on all the patients, and the overall analysis suggested that the mean dose that was received for 98 tumors was about 169 gray, mode of 90 to 120 in a range of 0 to 570. So to a non-radiation oncology audience, you may be asking, well, what does that actually mean? So to give you some sort of sense of what other tumors are treated for, where radiation oncologists will treat tumors for external beam, with external beam radiation, they're usually looking on the order of like 60, 70, maybe 80 gray, okay? And they're always concerned about not giving the normal liver tissue too much. They usually don't want to cross 30 gray, because that's considered their threshold where you're going to start to do damage. So it turns out that we're actually very, very high in terms of that sort of standard of what's done in radiation oncology. The normal liver tissue in the 56 cases evaluated received a mean dose of 67 gray with that mode and range. So again, this may be a little bit concerning because you can see that, sure enough, we're well over 30 gray. However, I should say that that 30 gray number is a whole liver dose. So if the entire liver receive more than 30 gray, it's considered to be bad for the patient, and then they would undergo hepatotoxicity. If you're only irradiating a portion of the liver, or maybe just one lobe of the liver, then the liver can actually tolerate more. And so if you're not injuring all the tissue, you can actually get away with higher amounts of gray and not necessarily put the patient in trouble. So this is a histogram that shows the amount of radioactivity, the amount of dose, the amount of gray that was given to each of the tumors. And so you can see that most commonly we fell into this sort of 90 to 120 gray range. However, I would like to point out there are some tumors that received even upwards of 500 gray, which is clearly overkill. And then there are a few that are subtherapeutic that probably did not receive enough gray. So sort of the important point here is that this sort of knowledge was not even known. It was not even known what kind of gray the tumors are given. And now that we have some sort of idea what the tumors are actually given, maybe that we can tailor the treatment differently to sort of fit what is necessary. Because you can kill a tumor with 500 gray, but the thing is that the distribution of these yttrium-90 is not solely confined to the tumor. A lot of it will go into normal liver tissue. So you end up putting the patient at a lot higher risk. So even though this is going to be a tumoricidal dose, anything over 200 gray would always be considered a tumoricidal dose as well. So you can get away with less activity and still do your job. And then these patients that are over here on the low side, we have to wonder how many of those patients are actually going to fail treatment because they're probably not getting an adequate radiation to their tumors. So the response evaluation and figuring out whether patients were responders or non-responders was equally interesting to us. And so we used a commonly used criterion to categorize whether they respond or not. It's known as M-RESIST, or modified RESIST. It stands for like response evaluation criteria in solid tumors. And so the modified RESIST basically takes kind of the longest diameter of a tumor, and it looks at how much change there is in that diameter versus what you started with. And the modified part of it takes into account necrosis. So you can see we did this for all of our tumors. Here we have the different liver segments and where the tumors were. Here's the mean tumor gray that the tumor received. This is the size before treatment. This is the size at follow-up. So you can see, like, for example, some of them would get larger, but then they were all necrotic, so that was considered to be a complete response based on the M-RESIST criteria. And then here's a follow-up time. Generally, we're somewhere between 3 and 6 months between these two scans that were done for the assessment. And generally, they were CTs, sometimes MRs. But you can see that we basically looked at who had complete response and who had partial response, and we did this for all of our patients. And then we looked at the non-responders, and for that we considered who had stable disease and who had progressive disease. So using, again, the same M-RESIST criteria, you can see that we had a couple that had progression, and the majority of them fell into the stable category, sort of in a similar fashion. And to sort of summarize all that information, you can see here that we had 8 complete responders who received a mean dose of about 228 gray to their tumor, 13 partial responders who got about 206, 24 stable disease, they got 154, and 3 with progressive disease, they got 277. And so I always look at that and I say that 277 looks a little confounding to me. You know, like I would think that those people would have responded. And at the same time, n equals 3 for that. So, you know, maybe it's some sort of statistical anomaly or something. But for whatever reason, those progressive disease patients, or maybe they just had bad biology of tumors and no amount of gray was going to stop their tumor. That's also possible. When we looked at the overall statistics, we saw that our responders received a mean tumor growth of about 215 gray, and our non-responders received about 167. So again, I think that this is actually very valuable information because it tells us that maybe you need to be above 200 gray to be tumoricidal. Maybe if you give the patient around 160 or 150, it may not be enough, and there's a chance that you might only be in a stable disease situation. So, you know, important, at least to, in HCC, it seems like it's important to get above that 200 gray mark. Now, we did not reach statistical significance. So it's only a trend. It was a 0.09 p-value. So even what I told you may not be true. So patients who went to transplant or died were excluded. There were 21 responders, 27 non-responders, and the association between mean tumor gray may indicate a trend but was not statistically significant. This is how the normal livers did. So here, our most common was in the 60 to 70 gray range. And you can see that, thankfully, there were many that got much less than that, which is good. But maybe somewhat concerning is that there are many patients who got even above 100 gray. And that's the kind of, of dose that maybe someone would be wanting to give to a tumor, but somebody's normal liver did receive that. So, this treatment is not without its potential complications and side effects. So we also looked at that and said, what kind of frequency of symptoms did the patients experience? So we looked at the dose versus the frequency of side effects. And so you can see we looked at patients who had jaundice, chest pain, nausea, vomiting, encephalopathy, etc., abdominal pain, ascites. By far, the majority of the patients had no complications, thankfully. But you can see many of them did have slight fatigue. Many of them did have ascites, and etc. And the ranges that of radiation that are there for many of these is quite wide, right? I mean, you can see, like, for example, if you look here in the slide, abdominal pain, we have one patient that got only 30 gray and ended up with that, and then one who got 90 gray and went with that. So I think it's difficult to draw any firm conclusions from this, but our statistician did come up at least with this much. We found that 37 patients had no to mild complications, and their average dose was about 65 gray. We found out that 15 patients ended up with one severe complication, and they got an average of about 64 gray. And 6 patients ended up with 2 or more severe complications, and they were there at 87 gray. So this would sort of suggest to me that we don't want to go too much higher than about the 70 gray level, or the patients are going to start to get into trouble. We did have a statistically significant association between the liver absorbed dose and the presence or absence of 2 or more severe complications. And every 10 gray an increase in the liver resulted in a 61% increase of the odds would have 2 or more severe complications. So I think in conclusion from this, we actually have some numbers that we can finally believe. It shows that the normal liver tissue may receive a dose which is non-trivial and may have some real biological effect for the patient. It also shows a possible dose-response trend for the tumors and complications resulting from the dose to normal liver. And I'm quite hopeful that these methods can provide the tools to help understand whether adverse events, success or failure, can be attributed to the dose which the tumor or normal liver received. So I feel like this is a situation where we've got imaging making a big step in sort of a therapeutic realm, and it's important for the Y90 community for sure. This was a joint project between nuclear medicine, interventional radiology, and radiation oncology. A list of my collaborators, and this work has actually been published. This is the citation for it, just published in October of last year. So I think I'll stop for a few questions before I go to my second topic. Does anybody have any questions? Hey, Dr. Mukherjee. Yeah, so great question. So generally it stays within the liver. And the way to really establish, so 2 things actually. In the glass product, the yttrium is within the glass because they neutron bombard, erbium, they neutron bombard a different isotope and create the yttrium within the glass. So there's no leakage of the yttrium outside. In the resin product, it's attached to the outside. So there is very small, I think it's like less than 1% dissociation of free yttrium that will occur. And that will usually end up into the urine. But then the other thing that I wanted to point out is that before the treatment is actually given, the interventional radiologist will map out the vasculature using conventional angiography, and then we'll do a technetium-99m MAA scan. So we give MAA kind of like a simulation, almost like they do a simulation in radiation oncology, and you map out, we usually use SPECT-CT, and map out the MAA distribution with SPECT-CT. There have been countless cases, I can tell you, of patients who will have MAA activity outside of the liver. It'll be in the stomach, it'll be in the duodenum, or it'll be in some other organ which you definitely don't want to radiate, and you might give the patient an ulcer of some kind. So this is key information. I'll always call the interventional radiologist and say, hey, look, you've got some collateral circulation that's putting some activity somewhere else. So with that knowledge, then when they come back for therapy day, they will go and coil embolize that particular artery that's feeding this part of the duodenum or feeding this part of the stomach or something, and make themselves feel comfortable that, yes, I'm not going to end up with any extrahepatic activity, and then we proceed with treatment. Another question? Yeah, so every patient has unique vasculature, unique perfusion situation, unique anatomy, and so many anatomical variants are there. And even the angiographers are surprised. You know, they'll say that this guy has a replaced gastric, or this artery is not where it should be and it's being fed from some other place. So this is really a situation where you have to do personalized medicine. Each case brings its own unique challenges, and you really have to understand the vasculature first and how the tumors are fed. Then once that is understood, then you can start talking about how am I going to give the radiation in a way that's smartest for the patient. So yeah, it really, really varies. Some of them are hypervascular, some of them are hypovascular. And so the more vascular they are, of course, the more activity that you can deliver. There have been some unfortunate situations. I can think right off the top of my head of a cholangiocarcinoma patient that was treated where we did a Y90 treatment, and most of the dose actually went to the patient's normal liver. Very little went to the tumor. And I think the problem here was that an MAA SPECT-CT simulation was not done in a short enough time before the Y90 treatment. The patient was a repeat treatment. And they had their MAA scan done 12 months prior to the treatment. Things had changed. The circulation had changed. And so I think we probably ended up doing that patient more of a disservice than a service. Other questions? Right. So you're saying to use the MAA, or you're just using an angiogram? So if there's a way to yeah, I mean, is there a way to quantitate an angiogram? Okay. Okay. So yeah, so this idea has actually never been suggested to me for actually getting quantitative information out of the angiogram. But the interventional radiologists, very often they do dyna CTs, or I think they call them C-arm CTs. So they're like low resolution, sort of not as good as a CT, but it is tomographic, and you get to find out, you know, what vascular bed that your contrast material is going into. So then the other sort of jump or assumption that you have to make is that when you come back for treatment, you're going to be in roughly the same position. And when I give spheres as opposed to giving iodine, it's going to be about the same. So this is where sometimes it may not be exactly true or not. And they tend to try to use the MAA as more of the simulation because the MAA particle size is almost the same as the yttrium sphere size. They're about 30 microns both. But it's an interesting thought, for sure. Other questions? Yeah. So typically they get 2. Typically. So and the reason why is because they want to do it in a lobar fashion just so they don't insult all the liver in one go. Now, if they are successful, if the patient's surviving, then sometimes maybe they'll come back for a repeat, so they could end up with 4 in a good case scenario if they're surviving like that. Yeah, we've done many repeat cases. Any other questions? Okay, I'll move on to the next topic. Okay, so I wanted to talk to you about some new biomarkers in oncology, proliferation, angiogenesis, and hypoxia. And this is, again, work that's been done at the Cleveland Clinic. So I was a local PI for a multi-institutional phase 2 clinical trial. which was sponsored by Siemens Molecular Imaging Biomarker Research. They were here in Culver City, but no longer exist, unfortunately. I was on their advisory board for hypoxia imaging as well. And the radiotracers that are in this talk are investigational. They're not FDA approved. So I would argue to you that, there is a lot of power in molecular imaging. And definitely there have been a lot of technical advances that have occurred over the years. When nuclear medicine first became approved for cancer imaging, at that time there was only PET. And about 3 years later, PET-CT sort of arrived on the scene and really sort of changed the landscape of things. And PET-CT is now a routine method for oncologic staging and monitoring treatment response. Before, there was SPECT. SPECT has been around since the 70s. And SPECT-CT is even more recent. I think the first SPECT-CT camera was around 2005. So this also has been a great leap forward technologically, and being able to pinpoint where all these activities are has been a great boon for imagers and clinicians. Then we had things like PSF reconstruction in PET, which would sort of mitigate the effects of the partial volume effect. Since all nuclear techniques are low resolution techniques, we suffer a lot from partial volume effect. Time of flight reconstruction is something, there is a time of flight in MR, but I'm talking here about PET time of flight reconstruction. Time of flight reconstruction is sort of another kind of leap forward in terms of image quality, where you actually use crystals that have a very, very fast timing resolution, and you're able to pinpoint your lines of where the activity is on a line of response with more accuracy, and actually make it into a segment of response as opposed to a line of response, and throw out a lot of noise information and thereby gaining a lot of signal-to-noise ratio. And PET-MR is probably the newest, just introduced about 2 years ago. Now that there are, I think all three actually of the big vendors that make PET cameras have their own versions of PET-MR scanners that are now combining MRI and PET information on a clinical basis. We actually had a PET-MR camera installed at Cleveland Clinic in 2013. And after about a 6-month sort of break-in period, we started using it on a routine clinical basis. And I can tell you, it definitely has advantages in certain situations. It's really great for pediatric tumors where the oncologists are concerned about radiation a lot. It's great for GYN cancer. It's great for colorectal cancer. It's very good for the tumor staging, doing the tumor staging, the local staging that's done with MR, in conjunction with the distant metastasis staging that is done with PET. So you're kind of getting both in the single go. And in tissues that are not good on CT, breast, prostate, brain, PET-MR holds a lot of potential. I think there we really need to have some advancements in the tracer technology to make the tracers that make PET-MR more attractive, I think, in those scenarios. So anyway, I would say the unique power of molecular imaging really comes from the specificity of our radiotracers and our biomarkers. So I'm going to talk to you about cellular proliferation, angiogenesis, and hypoxia. First, on the proliferation, some of the tracers that have been used are biomarkers of DNA synthesis. Probably the one that's most well known is F18FLT, or fluorothymidine. This is a DNA base pair for adenine, basically, and its incorporation into cells is basically a surrogate for the DNA synthesis rate. And so this is purported to have advantages over FDG, fluorodeoxyglucose, which is the more commonly an FDA-approved PET tracer, in that we're not confounded by inflammation, which may be occurring, or other reasons why there would be increased FDG uptake. Here we're basically looking at a DNA synthesis rate alone. So here are some others. These are uracil compounds, the FDAU, FNAU. Both of them are thymidine analogs, maybe a little bit less common than FLT. But generally, these are phosphorylated by thymidine kinase, and they're trapped in a cell according to a DNA synthetic rate. And the advantage over FDG would be an increased specificity. As I said, there should be a minimal uptake in inflammatory tissues. This could definitely be useful in radiation therapy or maybe stereotactic body The disadvantage, though, is that they often have a very low SUV. So SUV, for those of you who don't know, is standardized uptake value. And that's how PET scans are quantitative. The standardized uptake value basically gives you a ratio of how much activity is in a region of interest that you put down on the scan versus how much activity there is in the whole body. And so this allows us to sort of get a ratio of how hot or how aggressive maybe a tumor may be. So it's often a very low SUV, and it may be falsely negative in low-grade tumors, as in low-grade gliomas or in prostate cancer. So this is a picture of what FLT looks like, and also what FMAU look like. So you can see the F18 that's there on the ribose sugar. And there's an example of a patient with newly diagnosed glioblastoma. We've got an MRI here on the left. And then B is showing the FDG scan, and C is showing the FLT scan, both of which are showing uptake in the same area. The FLT is trapped by thymidine kinase 1, that's found in the cytosol. The uptake measures the cell cycling and DNA synthesis, whereas FMAU is trapped by thymidine kinase 2, which is found in the mitochondria. And so that's actually kind of measuring more the mitochondrial DNA synthesis. It's not really connected to the cell cycle, so I think that's another reason why FMAU is not so popular. But anyway, FLT may be used where the FDG background is high, like in the brain. FDG is very high in the normal brain, so it's not an ideal environment for FDG at all. Mediastinum or even small and large bowel, there's a lot of non-specific FDG uptake. And there have been some small-size human trials for FLT in lung cancer, gastric, rectal cancers, lymphoma, and gliomas. Results from initial studies in malignant glioma have suggested that a decrease in FLT uptake after chemotherapy is predictive of overall survival, and the baseline FLT was not predictive. So they're really looking at a change, and similar results were found in pilot lymphoma studies. The hope is that FLT will have a consistent correlation to the cellular proliferation rate, which is often measured by Ki-67. Many of you must be familiar with that assay. But that still sort of remains to be seen. This is an example patient here where you have a low-grade soft tissue sarcoma of the left distal thigh. And so you can see here, this is the FLT scan on the left side, the FDG scan here. And then looking at the different areas here, so this is FLT showing you the primary sarcoma, and you can see how avid it is on FDG and how non-avid it is on FLT. And this is where the site is on the CT scan. And here's the Ki-67, which is supposed to be proportional to this level of uptake. And then here are some lung mets. And then you can see the FLT uptake is here. This is how they look on FDG. This is where the tumors are seen on CT. But this has a much higher Ki-67 proliferation rate, and in turn has a higher FLT uptake. So what they're saying is that basically these are proportional. So the quantitation that's possible with FLT will directly tell you about Ki-67. Okay, so moving to angiogenesis. Angiogenesis is the formation of new blood vessels, and that's a key process in the growth of solid tumors. So thus could be utilized for diagnosis of malignancies. And non-invasive assessment of angiogenic activity is an interesting for response assessment of targeted anti-angiogenic therapies like bevacizumab or Avastin. The target for these are the integrins. So these are alpha V beta 3 receptors, and they play a significant role in that tumor angiogenesis. So they're a receptor for extracellular matrix proteins, and one of the classic peptides that are used for this are known as RGD peptides. So that's arginine, glycine, and aspartic acid. And so you can tag an RGD peptide and then basically see the alpha V beta 3 integrin expression. So it's expressed on low levels in epithelial cells and mature endothelial cells, but it turns out that it's overexpressed on activated endothelial cells of tumor neovasculature and some tumor cells. So here are some examples of angiogenesis radiotracers. F18 galacto-RGD is probably the one that's most commonly used or most commonly cited. Here you can see there a whole family of different RGD-type peptides. Some you can tag with gallium-68 or copper-64, which are positron-emitting isotopes that have a longer half-life. Well, actually, gallium-68 is shorter. That's only 1 hour. Copper-64 has a 12-hour half-life, so it's longer. And so any of those are potential options. And here's a schematic that shows what these molecules look like. Here's the F18 galacto-RGD. And so you can see that the RGD component here is a ring that will bind into the site. And they can make, sometimes they make big dimers out of these things. Yeah, that's a complicated structure. But anyway, this the schematic here shows that you can have a couple of integrin receptors that can be both bound at the same time to one particular radiotracer, taking advantage of maybe two RGD cyclical components, and therefore you get a kind of a tighter binding, or a more efficiency of binding to the target. So this is a 65-year-old male who has hepatocellular carcinoma metastatic to the lung and to the iliac bone. And so the PET images here are showing F18 galacto-RGD uptake along with CT and MRI scans. I can point out to you here, there's a lung tumor over here, and you can see this is a liver tumor over there. So there's some RGD uptake that's occurring in the liver over there, some mild uptake that's here in the lung corresponding with that, with this tumor in the lung. And we have, this is an MRI, so this is showing sort of a large, nasty metastasis to the iliac bone, and then you can see the strong RGD uptake that's coinciding with that. So let's move to hypoxia tracers. So one of the exciting tracers is the copper-64 ATSM tracer. And this is a thiosemi-carbazone agent. Most of the work for copper-64 ATSM has been done at Washington University in St. Louis. And I believe, I think it's Dr. Dadashti, she even has some clinical trials that are being run through Akron right now to look at copper-64, I think specifically in cervical cancer. But in any case, this is a nice agent because you get high contrast. Well, before, the mechanism is that it finds cells that have increased reducing power in the mitochondria in the presence of extremely low oxygen concentrations. So you can think that, in a normal Krebs cycle, you have O2 coming in and you have all these NADH2s and FADHs and FADH2s that reduce all these compounds, and that's how Krebs cycle turns and produces all the ATP in our cells. But if you don't have O2 present, then Krebs cycle doesn't turn. So you end up with sort of an excess of NADHs and FADH2s, and you get all this sort of pent-up reducing power. That's sort of the basis for how these hypoxia tracers get trapped. So the copper ATSM takes advantage of a higher contrast and quicker kinetics than the 2-nitroimidazole family, which I'm going to talk about next. And that's sort of maybe the more tried and true hypoxia tracer family. There's a lot more experience with the type 2 nitroimidazoles. But in any case, the ATSM is trapped in mitochondria, has high reducing power, and the free electrons will trap the copper ATSM, keep it within the cell. However, some newer mechanisms are proposing that this could be reversible and may occur in the cytosol as well, but I think that's okay. The potential disadvantage is actually the question to the specificity of trapping, as some studies are saying that there's discordance with binding of standard hypoxia stains such as pymonidazole. And I know that one of the people who's done some of the original work with copper-64 ATSM, I believe is a Japanese investigator, Fujibayashi, I want to say is his name. I attended a talk of his at one of the Society of Nuclear Medicine meetings, and he was showing some pymonidazole stains, and he was showing that they were not exactly concordant with copper ATSM distribution. So it's sort of casting a little bit of doubt as to whether copper ATSM is truly imaging a hypoxia or not. So take that for what you will. The hypoxia, the 2-nitroimidazole family is, as I mentioned, is the one that's sort of the more well-known hypoxia tracers. The one that's the most widely used by far is F18F-miso or fluoromyconidazole. Most of this work has been done at another University of Washington, the one in Seattle, actually. And they've been looking at this compound for many, many years. But the disadvantage of this is that it has a long clearance time and a low tumor to background ratio. There are a whole host of other hypoxia compounds that are there. There's EF5, which is very, very lipophilic. There's FASA that's been used in Australia. There's an I-124 labeled compound. There's Fetnin, which I think is also in Japan, or maybe it's FRP-170 that may be from Japan. Very, very hydrophilic. And the compound that I'm going to talk to you a little bit about is F18HX4. That's one that was produced by the Siemens molecular biomarker imaging group. It's a little bit faster than F-MISO and has a better tumor to background ratio. So here in the 2-nitromidazoles, we're still looking at a reduction from the electron transport change, which normally has oxygen present. The pent-up reducing power reduces these compounds. They're irreversibly reduced into an intracellular alkylating agent, and they stay within the cell. So the combination with the intracellular macromolecules effectively traps it, and it's tagged, and that's the reduced nitro group, and the tag radioisotope stays within the hypoxic cell. So here is a schematic of a copper ATSM structure, and here we have a F18 F-MISO structure. So you can see here, this is a cervical cancer patient. This is the CT. This is the FDG PET, showing a very FDG avid tumor here in the patient's cervix. And here you can see copper ATSM uptake. This is copper 60 ATSM, and this is copper 64 ATSM. Copper 60 has a very short half-life. I think it's on the order of like 10 minutes or something like that. So I guess we have a little bit of better image quality with the copper 64 product. This patient here is one who has a frontal glioblastoma multiforme brain tumor that shows strong F-MISO uptake. See a large tumor there. And then here we have a left temporal GBM glioblastoma again after resection with no F-MISO uptake, which is this sort of a photopenic area, which is always reassuring, telling us that probably there's no active tumor. So let me, I guess, get on a soapbox for a brief moment and say that the conduction of clinical trials, I think, is really very important, and it's really the only way that anything moves forward in medicine. You know, the only way to make any progress and gain new knowledge is through this process, no matter how painful it may be. So I want to talk to you about a trial that I was involved in using specifically HX4 in tumors, and we were basically trying to see what the reproducibility was in the tumor to background ratio of HX4 in patients who had a hypoxic tumor. So you may be asking yourself, why is hypoxia even of concern? So it turns out that both chemotherapy and radiation actually rely on the generation of reactive oxygen species, mostly hydroxyl-free radicals, and that's what attacks the DNA, and that's how they get their cytotoxic effects. So hypoxic tumors are actually found to be resistant to treatment. So if you could detect a hypoxic tumor early, then maybe you can tailor your treatment in a different way and somehow improve patient outcomes. Maybe you need to boost that area and give it more radiation, or give it a radiosensitizer, or do something else to have a better outcome. So the idea is that PET imaging of hypoxia could be useful in clinical management, and that HX4 has a potential to become a diagnostic imaging agent for identifying hypoxia. So here's the structure of HX4. It's very similar to F-MISO in the 2-nitramidazole family, but it has basically another imidazole ring compared to F-MISO, and that makes it a little bit more hydrophilic, gives it a better background clearance. It was found through phase 0 and phase 1 trials that it had an excellent safety profile, and so when we did this phase 2 trial, we were giving an IV dose of no more than 10 millicuries to cancer patients. We did dynamic imaging, with a list mode acquisition over the tumor for the first 60 minutes with a 90-minute static whole-body PET-CT. This study included tumors of head and neck, lung, rectal, liver, and cervical cancer, so many different types. And basically, all the patients had a baseline pretreatment FDG scan, which is like a standard of care scan, and then they had 2 HX4 scans. The patients that had tumor to background ratio greater than 1.3 would have another FDG and HX4 scan mid-treatment. If it was less than 1.3, the trial was over for that patient, and no more images were taken. If the patient had biopsy tissue available, it was collected to do some immunohistochemistry. And so the total study was competitive enrollment from 10 sites for a total of 33 patients, and Cleveland Clinic was one of the sites, so this was between 2010 and 2011, and we enrolled 8 patients locally. So as I mentioned, the primary objective was to test the reproducibility of HX4 uptake, And then we wanted to confirm the relationship between hypoxia and tumors and the related biomarkers that demonstrate hypoxia, like HIF-1 alpha or carbonic anhydrase 9, which are known to be hypoxia markers. And then our secondary objectives, we wanted to see if the agent's safe and if we can establish a threshold for hypoxia and collect some data to see if this is an effective predictor of a treatment response. So this is a schema of the trial. Basically, the patient would be enrolled. They would have informed consent signed, and then they would get their standard of care FDG PET-CT. And then within 2 weeks, they had to have an HX4 PET-CT, and they would have their vitals checked, et cetera, to make sure everything was fine. And either a day or two later, they would have a second HX4 PET-CT scan, both in the pretreatment setting, again to check for that reproducibility. And that was the main objective of the study. Then we asked ourselves the question, does the patient have a tumor to background ratio greater or less than 1.3? If it was less than 1.3, that's it. Patient is out of the trial. If it was greater than 1.3, then they would go on in the trial. Typically, they would undergo treatment. So in many cases, radiation. Sometimes it was chemo. Sometimes it was both. And so after about 4 weeks, they would get another FDG PET-CT and another HX4 PET-CT to sort of see how things change. And then after all that, in a 3-month follow-up, then they would get a CT for a RECIST evaluation. So these were the 8 patients that were enrolled in our trial. And you can see that half of them were lung cancers. We had about 3 rectals and 1 head and neck cancer. And while 8 patients is not enough to do any sort of statistics on, you can see that looking at the tumor to background ratios between scan 1 and scan number 2, that roughly they're sort of in the same sort of realm. This first patient, actually I'll tell you a quick funny story. So when this trial first started, I was very excited that we got this first patient enrolled. And so anytime a new trial starts and you get the first patient, it's a major hurdle that's been crossed. And so this patient came, and she had a very large lung tumor. And she came, got the HX4 injection, no problem, went home. It was a Friday. And then when I came back to the hospital on Monday, I had a message on my answering machine from the local community emergency room. And we have a hospital in this place called Parma, which is a suburb of Cleveland. Apparently, she had gone home, eaten a sandwich, fell asleep, took a nap, and then kind of woke up in a panic and thought that she was having a heart attack, felt some chest pain and shortness of breath, and, called 911. So, when the EMS arrives there, they ask her, so what's the problem? Why do you think you're feeling the shortness of breath and the chest pain? She says, I don't know, but I got this experimental radiotracer at the Cleveland Clinic, and I'm sure that's the reason why I'm feeling like this. So EMS doesn't know any better. I mean, right? They're thinking, okay, well, she got an experimental radiotracer. So they took her to the ER, and they admitted her, and they did observation, and basically when she got to the emergency room, everything was fine. She wasn't having an MI, she wasn't having a pulmonary embolism. All her tests were normal. So just to play it safe, they decided to admit her, and they observed her, and eventually they discharged her Saturday morning when I guess even the patient realized there's no reason for her to be there. So eventually I got this phone message from the emergency room, and I got filled in by a radiation oncology resident who was on call, and got the amusing story. But everyone in their charts and all the notes that were given were saying due to experimental radiotracer, and but the general public doesn't know that radiotracers are given in such small quantities that generally they don't cause any reactions. It's just not even enough like moles of molecules to create any sort of reaction. But the official diagnosis for the patient, you'll be happy to know, was a panic attack. So that's what happened. So on Monday, I called her back, and I said, I understand you had a very adventurous weekend. And she said she did, and she said, if it's all the same to you, I'm going to withdraw from the trial. I said, no problem, I understand, it's your decision, I don't want to force you to continue, and I thanked her for her participation. So anyway, HX4 is fairly reproducible, about 24 to 48 hours apart. But the choice of the background has a very significant impact for the detectability. So, and if you ask me, I think this is actually maybe a flaw in the trial design. In retrospect, I can say that. Because the trial criteria was such that the tumor to background ratios were set up so that the background was calculated in lung cancer as the contralateral lung. Well, if any of you have ever seen any scans from the lung, generally they have like no activity in them. SUVs are very, very low. So that's going to artificially inflate the tumor to background ratios in the lung. And then all other cancers have their background defined as the bicep opposite to the injection site. Tissue is going to have activity, so therefore their tumor to background ratios are lower. So the effect was that the lung cancer patients preferentially had higher to TB ratios and ended up being more likely to qualify for the mid-treatment scans. And like I said, it's sort of a trial design flaw, but that is what happened. This was the same first patient I was just telling you about. You can see she had a very sizable tumor here abutting her mediastinum with a very aggressive FDG uptake, SUV max of 17. Just to give you some sense, if you're not familiar with SUVs, 2.5 sometimes is used as a cutoff between benign and malignant. So it's highly malignant. And here's her HX4 activity. You can see that with a tumor to background ratio of about 5.1 pre-therapy. So it seems that there was uptake in that tumor, SUV of 2.6. This patient, eventually, she received 36 gray of radiation and was on 4 weeks of chemotherapy with cisplatin and etoposide. And her tumor did respond a little bit, but we still have a very aggressive 12.4 SUV here. Of course, since she withdrew from the study, we don't have any follow-up HX4 imaging or anything like that. But this particular image here illustrates how there is some concordance and discordance between the distribution of both FDG in the red contour, so this is FDG here in the red contour, and this is HX4 in the blue contour. And so you can see that there are overlapping areas and there are non-overlapping areas, which I think is also interesting because sometimes, according to the Warburg effect, if you've got something that's very, very metabolically active, it may be doing a pure glycolysis and it's all taking up a lot of FDG, but not necessarily undergoing oxidative phosphorylation, and therefore there may be a hypoxic signal. And then there's areas that are not like that. The next patient was an 85-year-old who had lung cancer. Here you can see a pre-therapy SUV of about 10.7 and a post-therapy FDG after 4 weeks of SBRT of about 10.3. So you think, okay, she had radiation therapy, but not really much change. She didn't respond too much. Well, no, she may not respond. So what happened on the hypoxia side? Well, she had a good amount of hypoxic uptake in the pre-therapy scans. These are both the pre-therapy scans here. You can see with a 5.3 and a 4.4. And the post-therapy HX4 that was done in this time also still had hypoxic signal with a tumor to background ratio of 4. So one might infer that she has a hypoxic tumor and it's persistently hypoxic after therapy and may fail treatment. But her follow-up, so this is her CT. Here's a pre-therapy CT. That was the original tumor. This is her CT 3.5 months after SBRT. You can see all this radiation pneumonitis. So that happens in almost all the patients who get SBRT. There's lots of like infiltrates and sort of reticulations that occur within the lung. And it may look alarming, but often the patients are not symptomatic at all and they're fine. It's sort of a transient radiation pneumonitis, a transient inflammation, and it resolves. Sure enough, 6 months after, her CT essentially shows a complete response. The tumor has vanished. You can see just a little bit of thickening here along the major fissure of the lung. And the FDG is blank. There's no tumor. It's a complete response. So even though there was some hypoxic signal, this patient responded. This particular patient is a 49-year-old female with rectal cancer, had a very high pre-therapy FDG uptake in the beginning. After therapy, the SUV did come down to about 7. This patient also got radiation and chemotherapy. You can see there wasn't that much in terms of HX4 uptake. They had low ratios, about 1.5 and 1.4, and post-therapy was only 1.1. So maybe you could say this is not really a hypoxic tumor, and hopefully the patient will succeed in treatment. This one is a very interesting patient. It's kind of the opposite situation of the previous one I showed you. Here we have a very high SUV, again, of 12.2. And after therapy, the SUV is climbing. So this either means that the tumor is progressing and the patient is getting worse, or there's a lot of inflammation that has occurred from the SBRT treatment, which is kicking the SUV up about 3 points. In any case, the restaging CT here, 3 months after SBRT, showed definite residual disease. So this patient has failed treatment. And here the HX4 shows a strong hypoxic signal. We've got tumor to background ratios of the 6, and in the post-therapy, setting, the tumor to background ratio has increased even higher. So I would venture to say that this patient truly does have hypoxia and has failed treatment because of it. Now, in this particular patient, I also did this contour just to show what the overlap was. So here the FDGs in red, the blue and the green are the two different HX4 scans. And you can see the two hypoxia scans are fairly closely aligned. There is a little bit of variation, but it's not bad. And then this is the list mode data, the dynamic list mode acquisition, which is actually showing the time activity curves. So what you see is the first spike is the input function, or the spike that you get up from the tracer first entering the blood. The blue here is the muscle compartment. The yellow is the lung. The dark blue here is the tumor, and the purple is the aorta. So you can see that both the tumor and the aorta are sort of falling down together as the tracer is sort of going through the blood volume. But I think the important thing here, and eventually it's going to stabilize out, this is only 1 hour, the important thing here is to show how the muscle reaches a nice steady state and the lung keeps falling. So I think it really proves the point that the lung is not a good background, not a good choice for measuring background. Really, all the background should have been done according to the muscle, since it reaches a much more nice steady state. And this is the last patient. This was the 63-year-old with head and neck cancer. Here we had a tongue-based primary, which was very FDG avid, and there was a big level 2A lymph node here on the right side. And the pre-therapy HX4 was essentially negative at both sites. And of note, this patient was HPV, or human papillomavirus positive, and those patients tend to do a little bit better than the HPV negatives, with the theory that HPV negative tends to be more hypoxic. So maybe that's the reason why there's no hypoxia. But in any case, the restaging FDG PET done about 5 months afterward showed that the tumor had resolved. All you are seeing here is some physiologic salivary gland uptake. So the patient responded well. So rather than a conclusion, I'll give you my sort of comments or thoughts on this. I think this trial illustrates to us that assessing patients with a FDG PET scan 4 weeks after therapy can be confounding because of post-radiation therapy inflammation. It's really better to wait for at least 12 weeks when the radiation subsides a little bit. I'll say that when HX4 uptake, even though it's reproducible, sometimes it's only faint activity and sensitivity specificity is really unknown. The immunohistochemistry analysis of the biopsy tissue did show a correlation between the CA9 expression and the HX4 uptake. So that's a positive finding, telling us that HX4 may actually be demonstrating something real in the tumor. But no similar relationship could be established between HIF1 alpha and HX4 for whatever reason. The dynamic data suggests that muscle activity reaches a steady state plateau in about 30 minutes, and that would be the best standard to use as a background. Imaging is reasonable in the 60 to 90 minute time window. And I think the greatest utility for this may be in HPV negative head and neck cancer because of the tendency for bulky nodes with necrotic centers which don't respond well to XRT. Also, that cervical cancer is known to have a lot of hypoxia in it, so therefore this sort of tracer may be useful in that population. And we have been undergoing some talks with Threshold Pharmaceuticals, just as the company in San Francisco, which has now bought the rights. They own the IP for HX4. And we've been talking with them about doing a trial in head and neck cancer. So I, again, want to acknowledge my radiation oncology partners and some folks at Siemens Molecular Imaging for funding and support. And that's it.